So when we talk about endocrine, the basic concept is, of course, is that they are endocrine gland. Endocrine means they don't have any ducts. So these are ductless glands. They release their hormones throughout the body, and that hormone will reach their site of action using the circulation and then act upon that. That's the basic concept of a endocrine action or a hormone action in that perspective. So when we talk about chemical messengers, there are three broad classes of chemical messenger. One is that this chemical, we said, is released by a gland. It goes through the blood circulation to a distant part, acts on a separate part. This is the endocrine process. The second process is that it can actually be released, and within the closed environment, it will have an effect. This is known as the paracrine effect. And finally, it can come back and acts upon the same gland, which is known as the autocrine effect. Now, can the same hormone have different effects, or different substances will have different effects, Vibha? So same chemical can have an effect. So growth hormone can go and act on the bone directly. It can affect the cells close by, and it can affect the somatotroph, which is producing growth hormone. So the same chemical can be autocrine, paracrine, and endocrine effect. It's not that they are different effects altogether, but yes, certain substances are more acting in a local environment. Certain substances are acting more in a distant environment. I think this is something which is important to understand in that regard. So when we talk about paracrine signaling, so what happens in paracrine signaling is that the signal is produced in a local microcosm, in a local environment. Now, how do you ensure that this signal doesn't leak out? So that's why you need to have a lot of binding proteins. And these binding proteins will target them to the receptor, but they will not allow them to leak out. So that is why if you talk about local acting substances, you will have a lot of binding proteins. Can you name a few? So which systems, endocrine systems, have got more binding proteins?
IGF.
So IGF systems will have a local binding protein, and these protein will ensure that they stay there. So generally we say, or if we forget about this part, which type of hormones require binding protein? So steroid hormone require, and peptide should not require, because peptide will anyway run through the blood easily. So the question can be the opposite way. Why do IGF require a binding protein and insulin do not require a binding protein? Because IGF-1 have to usually act locally. So growth hormone, one is that of course growth hormone goes to the liver and works there, and then from there it goes. But there is also local production of IGF-1 in various tissues. You don't want that IGF-1 to escape. So IGF-BP3 will take it from the liver to different parts, but then different IGF-BP2 will play a different role in different sites. So you have got BP2, which is acting in certain areas BP5 will be acting. And what it will do, it will have a selective delivery. Cells which do not need to be exposed to IGF will be bound at that point of time. But where you want, you will release it. The advantage is that you will not have uncontrolled growth. You will have regulated growth. So this binding protein is not just carrying your substance from one place to the other. It is changing the bioactivity. It is providing target in that perspective. And that is why it brings us to an important question, that if you treat somebody with growth hormone and you treat somebody with IGF-1, what is the major effect as far as the adverse effects and the possibility of a tumorogenesis is there?
Adverse effect will be because when I give IGF-1.
Okay. So you will have much more IGF-1, but your IGF-BP level is not increasing. So that's why this IGF-1 will become run amok. You have got an elephant which is out of control. It will destroy your own army rather than going toward that side. But if you have growth hormone treatment, you have got both IGF-1 and IGF-BP, so you will have a more guided, a gradual and a better response. So anybody who has a problem in the IGF-1 deficiency, you can say, I can give IGF-1 to anybody, even if it is GHD. Why not give IGF-1? The answer to that is that if you do not give growth hormone, your IGF-BP will not rise. Your half-life will be less. Your levels will go up and they will come down. You will have hypoglycemia because of that. Acute rise will cause hypoglycemia. And second, long-term rise will cause development of malignancy and other aspects. So one unique aspect of paracrine signaling via peptides is that you need a binding protein. Can you mention about any other peptide which has got a lot of paracrine effect, which is crucial for growth? So PTH related peptide, a lot of these compounds are all locally acting. They are not involved in the systemic regulation, but they are there locally and they are very, very important. What is the difference between the receptor of PTH and PTH receptor protein related peptide? How much is the difference between the two? So they are the same receptor, but then the location of the receptor is different. For the PTH, of course, your receptors will be at the level of the proximal tubule, where they will produce 1-alpha hydroxylase, at the level of the collecting duct, where they will cause calcium absorption at the bone. But PTH, RP, the receptors will mainly be the cartilage area. So that is why they have a different effect. So very interestingly, same receptor, different effect. This is what we'll talk about, how you can have complexity of the endocrine system in that regard. So this binding protein causes a localized effect, which is tightly regulated and selective. So people have thought of strategies like if you want to treat some form of cancers which are IGF-1 dependent, you can alter the IGF binding protein. So this is one of the theoretical aspects you can think about how you can alter, decrease the IGF-1 expression in that perspective. So endocrine signaling, typically we know the signal, of course, comes directly into the blood. Now, how is that your blood level of cortisol, do you think is different in the heart, or let's say is the level different in the upper limb or lower limb or bone or heart? What do you think?
The level will be the same for the.
So then what decides the action?
How much receptor are present there, how much sensitivity of receptor.
So one, you are saying that the effect of a particular hormone in a particular organ system will depend one upon the concentration. Now concentration we measure in the blood, it's pretty much the same. Second, you are saying whether the receptors are there or not. That is important. Third, the density of receptor which is there. Other, your binding protein, it will deliver it to you. So you ordered somebody who is packers and mover, they're taking your hormone from one side to the other, they will deliver there. So whether it's being delivered there or not, and very important, you said last was metabolism. So you will have local systems which will decrease or increase the effect. So if we talk about a pro-hormone like testosterone, what is the local metabolism of testosterone? Yes. So testosterone goes to a tissue. What will decide that it will act via the estrogen receptor or whether it will act via the androgen receptor? So essentially, testosterone, I'm saying, is a pro-hormone. It needs to be converted into estrogen using aromatase, or using 5-alpha reductase, it will be converted into androgen. So if suppose you have somebody who has skin exposure, there it will be converted to DHT. But if you want to go to the pituitary where growth hormone is to be secreted, it has to be converted into estrogen. So local metabolism will be important. The other important is, of course, local metabolism is cortisol. So what happens there? So you will have a shield of 11 beta HSG2, which we discuss a lot around the mineralocorticoid tissue. But what about glucocorticoid responsive tissues?
And glucocorticoid responsive tissues, cortisol needs to be activated.
So cortisol, so you need more amount of cortisol there. So you will have enhancers there, while you have inhibitors in the area or a shield which is there in the mineralocorticoid tissue, basically in the kidneys, in the sweat gland, in those areas where you don't want the glucocorticoid to act on the mineralocorticoid. So the selectivity of the effect of a hormone does not depend upon the concentration. It depends upon the binding protein, its delivery, receptors, local metabolism, and other factors which are there in that perspective. So this signal will go and act on the receptor, and then it will have an effect in different parts as well. So basically, depending upon the activity and metabolism, you will decide about how this will work or not work in that perspective. Now, if you have an inactivating enzyme, that's what I'm trying to say, is that it will not act in those tissues where you have an inactivating enzyme. The classical example you give is 11 beta HSG2, which will inhibit or deplete the amount of cortisol in the mineralocorticoid tissue. Because now what you need to understand is that this is a distant effect. So you send so much, it will reach less in the periphery. You need a higher concentration of the hormone here. The selectivity is largely driven by the receptor with an effect of local metabolism. Now, if you use this principle now, we talk about the hypothalamus, the pituitary, and the end organ. If I ask you which hormones will be the maximally concentrated in the body and which will be the lowest concentration, what will be the one? Okay. So this is why you know that the ratio of, let's say, how much will be the TRH in that will be picomole, very, very low. ACTH also very, very low. Cortisol, you start talking about microgram. So you will have 1,000 times more concentration for the actual hormone as compared to the regulatory hormone. The reason for that is in that perspective. Now, what we need to understand is that the same hormone can have multitude of effects, even if the receptor is the same. This is also important. So we said that for same concentration, the effect is different. Now I am coming to the second point. Same hormone has different effects. So we know growth hormone has a classical endocrine effect, growth hormone receptor, which is basically, we'll talk about all that how it works in that perspective. You've got the cytokine receptor, which is there in that perspective. And binding will activate the JAK-STAT pathway to activate IGF-1. Now, this IGF will cause the growth. This is the classical somatomedian hypothesis, growth hormone, IGF-1 growth. But what you need to remember is that growth hormone can go and locally act on the growth plate as well. This is basically known as the effect there, which will be paracrine, produce local IGF-1. Now, this IGF-1 will not go into the circulation and there it can act locally. So even if your IGF-1 level is lower in somebody who is treated with growth hormone compared to somebody who's treated with IGF-1, which one will grow more? Because you have local effect as well. There is also a third effect. The growth hormone will also have a local effect on the growth plate itself. That will be IGF-1 independent. So what you need to remember is that same hormone can have multitude of effects, and that's why often the manifestation will be different. So how are the manifestations of growth hormone deficiency, GHRH receptor problem, and GH resistance vary? So one, you have got no GHRH action, so everything beyond should go off. One, your growth hormone is not there, and third, your growth hormone is not acting. So what is the difference in the phenotype?
The GHRH problem will be the milder because the growth hormone is going for a different aspect, and the GH.
No, but growth hormone receptor, GHRH is not there, so how is there the growth hormone? So GHRH receptor is not there. So you may have more GHRH which is produced. So GHRH may also have effects which are beyond its receptor. There may be some other effects. So their manifestations will be different. They will not have hypoglycemia. They will not have micropenis. If you have GHD, you have got classical features: micropenis, hypoglycemia, mid-facial hypoplasia, sparse hair, pot belly, all those things. But what about growth hormone insensitivity? So, but the difference is largely, so if I talk about this, growth hormone deficiency is IGF deficiency, plus you have got a growth hormone direct effector also not there. If you have growth hormone resistance, only you have got the IGF-1 related effects which are not there, but the growth hormone effects are there. So you can say this is plus minus something like that. This is A plus B, and that is A. So B will be different in that perspective. So that's why you've got a different phenotype altogether. You have got much more frontal bossing. You have got much more sparse hair, coarse faces, and those parameters will be there, which you will identify from that perspective. So this basically means is that a lot of effects can vary between hormones because they are acting differently. Now, understanding this physiology is very important, because if you understand this pathophysiology session, which may take 2 to 3 sessions probably, they will cover the entirety of pediatric endocrinology. So this will work like a revision as well as covering a lot of things. So what I've tried to show is that one hormone can have multiple effects. The other interesting thing is that same receptor may be acted upon by 2 different receptors. And this is what Vibha was talking about. Parathyroid hormone, which is a classic endocrine hormone, And you have got the PTH-RP, which is a classic paracrine signaling acting via the same receptor. So one controls the bone growth and the other controls the cartilage growth. So what are the difference between manifestations of PTH defect versus the PTH-RP defect? Yeah, manifestations. So if you have somebody who's got no PTH, what will happen? So everything will be normal. They will present to you at
later,
when?
like afterward.
So around first week of life, classical most severe form DiGeorge syndrome present by 1 week of life, but other things, skeletal manifestations, everything will be normal. So that is PTH problem. If you have a type 1 PTH receptor problem, what will happen?
Then this will not take the pH.
So
there will be skeletal dysplasia.
So you will have Bloom strand skeletal dysplasia. So now this again is a unique model. If you talk about PTH problem, it's just PTH problem. Type 1 PTH receptor defect, you got PTH plus PTH-RP problem. So if you subtract that, you will get what is the effects of PTH-RP. So the major difference between Bloom strand and hypothyroidism is huge. Bloom strand has got severe dysplasia in birth. Your cartilage is not being formed. If your cartilage is not being formed, your bone will not be formed. So that may be a lethal phenomena. So while type 1 PTH receptor defect will be much more severe, a primary hypoparathyroidism will not have that much problem in that perspective. So we have talked about how one hormone can have multiple effects, how two hormones can work to the same receptor to have a different effect. Now we also know that pleiotrophy also, that similar place, different places, it will have a different effect. And of course, we talk about thyroid as it affects everywhere, affects the bone strength, brain function, cardiac contractility, thermogenesis, growth plate, and motility. So when you talk about endocrine disorders, there may be varied manifestations which are there, which you need to be aware about in that perspective, in that regards. The other contrary phenomena is redundancy. So for which parameters would you think the body will have more redundancy? So those which are vital for survival, the body will try to conserve it. So when you talk about redundancy, what does it really mean?
More than one mechanism to control the single factor.
So you have a fallback mechanism. You've got, let's say, some important personality you want to protect. You will have an outer ring, then you will have an inner ring, then you have a central ring, so then a bodyguard. So a lot of various. So if one thing goes wrong, second will be fine. The classical example I am giving here is hypoglycemia. So you've got 4 hormones which are countering hypoglycemia: growth hormone, cortisol, epinephrine, and glucagon. And therefore, if you have deficiency of one, doesn't matter. Have you seen any GHB causing hypoglycemia? So how many? Only one. Any isolated cortisol deficiency causing hypoglycemia? Yes. So it may happen in adverse circumstances. But if you have multiple predatory hormone deficiency, they will have hypoglycemia immediately. That's why the main issue. What about glucagon deficiency and epinephrine deficiency? So do you think glucagon and epinephrine deficiency have any role in hypoglycemia? In which condition? The most common cause of hypoglycemia is actually attributed by glucagon and epinephrine deficiency. That is pancreatitis, type 1 diabetes. So in type 1 diabetes, when you have hypoglycemia, you fail glucagon, you fail beta system already. So this is often common. So if you say from an overall perspective, they have a role, but isolated epinephrine deficiency, so many patients with epinephrine so deficiency, you like, what could be the case of epinephrine deficiency you can think of? No, suppose somebody has got adrenalectomy done for pheochromocytoma. Do you give them epinephrine? You don't give them epinephrine, you give them hydrocort. So what it tells you that to maintain, and they don't have hypoglycemia. So it means epinephrine 0 also you will not have hypoglycemia. But in type 1, what is happening is that you are giving insulin also. So insulin is causing hypoglycemia. Body is not able to counteract that. So glucagon deficiency and epinephrine deficiency may cause in exceptional circumstances, when you are having hypoglycemia, it may worsen. Cortisol deficiency and growth hormone deficiency may isolated cause hypoglycemia in situations when you are very sick. Somebody develops fever, vomiting, not taking, then they will develop. But two combined, growth hormone and cortisol deficiency, they will develop even in day 1, day 2 of life, they will develop hypoglycemia. So this is the importance of redundancy. So the more the number of hormones which are protecting a system, the more important it is. What are the other examples of redundant system? One is we talked about glucose, then second. So calcium, you have got how much? How many?
Calcitonin.
Calcitonin? Calcitonin is a hypocalcemic hormone. So PTH and vitamin D. And then what else? So RAS and AVP. Sodium, roughly similar you can say. So it's important places you will always have multiple systems which are there. Now, how many systems regulate puberty? Does puberty have a redundancy? Or growth? Let's say growth has a redundancy.
Growth is dependent on multiple factors.
That is different. But if you not have growth hormone, will you grow?
Not growth normally, but 2 to 3 centimeter growth will happen.
Yes, but you will not, of course. So that is different. So of course, if you don't have cortisol and you don't have growth hormone, you won't have zero sugar. You will have 20, 30 sugar will always be there. Na? You will never have zero sugar. But when you say your height is 100 centimeters versus 150, that of course means you are not growing. What I'm trying to say is that can isolated growth hormone deficiency cause growth failure? That is very important. Similarly, if you have an isolated gonadotropin deficiency, you will have delayed puberty. No, that is important. So these less important things you have got no redundancy. Body doesn't want to waste energy. See, these are all wastage of energy. You have got 4 hormones acting all the time. But here, you don't grow, that's fine. You are not going to die because of that. So body is allowing it. So if you have growth hormone deficiency, you will not grow. So these are systems which are non-redundant in that perspective. Which is the most important system for the survival of a species? Besides, let's say, of course, if the person dies because of sodium, glucose, and all those is different. But from a species perspective, which is the most important endocrine function which is relevant? Reproduction. So, do you think reproduction has redundancy?
There is this accelerated growth. I know this.
And what is the most important regulation of reproduction science?
It is the field given multiple genes.
And what else? So final regulator of everything for reproduction, fertility. Which system? GnRH. So does GnRH system have redundancy or not? What is the inheritance of hypogonadotropic hypogonadism? Kalaman syndrome is X-linked, but they have got also an inheritance which is known as oligogenic inheritance. What do you mean by oligogenic, Sayan?
More than one gene regulating it.
So it is another way of showing how important it is the genetic redundancy. So we talked about hormonal redundancy. Here you have hormonal redundancy for glucose, for calcium, for electrolyte and all those things. There is a genetic redundancy. Similarly, you have got genetic redundancy for eye. So there are multiple genes which regulate. So oligogenic inheritance like Lawrence moon beetle, you will have an eye problem only if multiple genes are affected. So similarly, since reproduction is very, very important for a species, they have got a genetic redundancy. This is hormonal redundancy. So that is important to understand. But for an individual perspective, so for an individual, if the GnRH is not there, they don't have any other system. They won't have another alternate system that, okay, if your GnRH is less, you've got this particular hormone which will take care of your growth. No, there will be no growth. Similarly, if you don't have growth hormone, you won't grow. That is fine, because for an evolutionary perspective, one person having less growth doesn't make a difference. But that person dying because of hypoglycemia makes a difference. For a species, everybody is having a problem in, suppose you don't have oligogenic inheritance, you've got multiple, everybody will become GnRH deficient, that will be a big problem. That is why they have a backup mechanisms.